Stop. Before you touch that remote, I need you to hear this. Somewhere in your house right now, there's probably a blood pressure monitor. And if you've used it recently, you walked away with a number. Maybe your doctor called it a little high. Maybe they said borderline. Maybe they handed you a prescription. Or maybe they smiled and said everything looks fine. I want you to consider something that took me 30 years of clinical work to fully understand. That number you got, in most cases, it's incomplete. And incomplete medical information, delivered with complete confidence, is one of the most dangerous things in medicine. Here's what I mean. 2 patients walk into my clinic. Patient A has a reading of 148/90. Patient B has a reading of 152/64. Standard medicine flags both. But what standard medicine misses is that patient B is in significantly greater danger from a very specific kind of cardiovascular damage, and her bottom number being so low is actually the warning sign, not the top number, not the number everyone's focused on. Meanwhile, patient A might have taken his reading after rushing across a parking lot, sitting in a hard waiting room chair for 40 minutes with a full bladder and crossed legs. His real blood pressure might be 128/78. He could walk out of that office with prescription for a condition he doesn't have. These are not rare edge cases. These are things I watch happen constantly. Today, I'm going to give you the complete picture, not a simplified version, not a just talk to your doctor brush off, a real evidence-based framework for understanding exactly what your blood pressure readings mean, specifically for a body that has been running for 6, 7, or 8 decades. By the time this video ends, you'll know how to calculate a number that predicts cardiovascular risk better than the numbers your doctor actually writes down. You'll understand why the most dangerous window of your entire day is probably the first 90 minutes after you wake up. And you'll know the 5 measurement mistakes that silently add 30 or more fake points to any reading. Stay with me. This is information your 12-minute office visit will never give you. Here's the first thing most people over 60 don't know about blood pressure. The rules change as you age. And I mean genuinely change, not in a small way, but in a way that fundamentally alters how every reading should be interpreted. Let's talk about what's actually happening inside your arteries right now. When you were young, your artery walls were elastic. Think of a healthy artery like a balloon. When the heart beats and sends a pressure wave out, the artery expands to absorb some of that force, then gently recoils. This is normal and protective. It cushions the pressure spike. It keeps the background pressure steady between beats. As we age, and this happens to everyone, it is biology, not failure. Those arterial walls gradually lose their elasticity. The technical term is arteriosclerosis, stiffening of the arterial walls. And when that stiffening happens, something very specific occurs with your blood pressure readings. The top number, which we call systolic, measures the pressure when your heart contracts and pushes blood out. With stiff arteries, that pressure wave has nowhere to go. There's no give in the wall. So the spike gets higher. The top number goes up. The bottom number, called diastolic, measures the pressure between beats when your heart is refilling. With elastic arteries, the artery stays slightly pressurized between beats because it's still pushing back from its last expansion. With stiff arteries, that recoil is reduced, so the between beat pressure drops. The bottom number goes down or stays flat. The result, the 2 numbers start moving in opposite directions. The top goes up, the bottom goes down or stays flat. This creates what we call a widening gap between the 2 numbers, and that gap is one of the most important signals in all of cardiovascular medicine. This specific pattern, elevated top number with a normal or low bottom number, is called isolated systolic hypertension, and it is the dominant form of high blood pressure in adults over 60. The majority of older adults who have elevated readings look exactly like this, not both numbers high, just the top. Why does this matter? Because isolated systolic hypertension carries a very specific risk profile that is different from the kind of high blood pressure most younger adults develop. And because the bottom number being low, which might look reassuring on paper, can actually be a warning sign in its own right. Data from the Framingham Heart Study, one of the longest-running cardiovascular studies in history, show that elevated systolic pressure in older adults was one of the strongest independent predictors of stroke, heart failure, and cardiovascular death, even when the diastolic number was completely normal. So if your doctor glances at your reading, sees a bottom number of 72, and says, well, the diastolic looks good, understand that this is an incomplete picture. The top number can still be causing damage, even when the bottom number looks fine. And that's just one part of what's missing from most conversations about blood pressure. Let's get specific. Because most conversations about blood pressure stay deliberately vague, and vague doesn't protect you. The most significant clinical trial reshaping our understanding of blood pressure treatment in older adults is called the SPRINT trial. Published in the New England Journal of Medicine in 2015, it enrolled over 9,000 adults, the majority over 60, and asked a direct question: does more aggressive blood pressure treatment actually reduce serious cardiovascular events? The answer was yes, but with important caveats that almost never make it into the headline summary. SPRINT found that targeting systolic pressure below 120 reduced the combined risk of heart attack, stroke, heart failure, and cardiovascular death by about 25%, and reduced all-cause mortality by roughly 27%. Those are meaningful numbers. But the same trial found meaningfully higher rates of acute kidney injury, dangerously low blood pressure on standing, fainting, and electrolyte imbalances in a more aggressively treated group. Real risks, real trade-offs, especially for adults over 75. So I'm going to give you the full picture, not just the upside. For adults between 60 and 74, arresting systolic consistently below 130 is a target. This is where you want to be. Systolic between 130 and 139 is acceptable, but worth monitoring carefully and worth an honest conversation with your physician. Systolic between 140 and 149 is what I call the early warning zone. Not a crisis, but lifestyle changes are clearly warranted and medication may be worth discussing. Systolic consistently at 150 or above over a period of at least 2 weeks. This is too high. This requires medical attention. Not tomorrow. Soon. For adults 75 and older, the targets shift slightly. Below 140 systolic remains the general goal. But how aggressively you pursue that target should depend heavily on your kidney function, your history of fainting or dizziness on standing, and your overall health picture. Systolic consistently at 150 or above is too high at this age regardless of how well you feel. For the diastolic, the bottom number, below 80 is ideal. Between 80 and 89 warrants monitoring. Consistently at 90 or above means your arteries and kidneys are under sustained strain. But here's the part almost nobody tells you. Diastolic below 60 is also dangerous in older adults, dangerously low, and this is a direction of risk most people never think about. Research published in the Journal of the American College of Cardiology, using data from a large, long-running health study called the ERIC cohort, found that consistently low diastolic pressure, below 60, was associated with significantly higher rates of silent heart muscle damage and coronary events, not because pressure was too high, but because there wasn't enough pressure between heartbeats to adequately supply blood to the heart muscle itself. A separate study published in the journal Hypertension confirmed that in older patients with isolated systolic hypertension, a diastolic at or below 60 was an independent predictor of mortality. I had a patient, I'll call her Evelyn, 77 years old, a retired librarian. She came to see me dizzy, exhausted, and frightened. Her systolic was well controlled at 126, but her diastolic had drifted down to 54 over several months on a multi-drug regimen. Her heart was not receiving adequate blood flow between beats. We carefully adjusted her medications. Within a month, her diastolic was back to 68. Her dizziness resolved. Her energy returned. Nobody had been looking at the bottom number going too low. Everyone was so focused on controlling the top number that they had quietly created a new problem underneath it. Watch both numbers, not just the top one, not just the high end. Both directions matter. Now I want to give you something that most physicians will never calculate for you during a standard office visit. It takes about 5 seconds. You can do it right now with any reading you've taken in the past week. It's called your pulse pressure. Pulse pressure is simply the difference between your two numbers. Your systolic minus your diastolic. If your reading is 148 over 78, your pulse pressure is 70. If your reading is 132 over 82, your pulse pressure is 50. That single number, that gap, is one of the most powerful cardiovascular risk predictors available in clinical medicine for older adults. And yet, most people have never heard of it. A landmark analysis from a Framingham heart study, published in the journal Circulation, found that pulse pressure was actually a stronger predictor of major cardiovascular events in adults over 60 than either the systolic or diastolic number considered alone. The same analysis found that from age 60 onward, diastolic pressure became inversely related to heart disease risk, meaning a wider gap between the two numbers carried more danger, not a narrower one. Why? Because pulse pressure is a direct, real-time measurement of arterial stiffness. Stiff arteries do two things simultaneously. They push the systolic higher because they can't expand to absorb the pressure wave, and they let the diastolic fall lower because they don't recoil between beats. The gap widens, and a widening gap means your heart is generating more mechanical force with every single beat, creating more stress on arterial walls, including the walls of the coronary arteries that supply blood to your heart muscle itself. Here are the ranges you need to know. A pulse pressure below 40 is healthy. Your arteries are maintaining good elasticity. Between 40 and 60 is acceptable, but worth tracking over time. Above 60 is a warning zone. This signals meaningful arterial stiffness and elevated risk. Above 80 is a serious signal. Let me give you a concrete example. If your reading is 165/75, most people look at that 165 with concern. And yes, that's a high systolic. But your pulse pressure is 90, and that number tells us that the mechanical stress on your arterial walls is severe. That 90 deserves as much clinical attention as the top number, if not more. Take any reading you've had in the past week, subtract the bottom from the top. Write that number down. If it's above 60, bring it to your next appointment and specifically ask your physician to address it. Most will not have raised it themselves. Now you will. I promise you something at the beginning of this video, a specific window of time when blood pressure quietly does its worst damage. Here it is. Blood pressure is not a fixed, stable number throughout the day. It moves, sometimes dramatically, in response to activity, stress, food, sleep, and the body's internal hormonal rhythms. And there is one predictable window, documented across multiple major studies, when this surge reaches its peak danger for older adults. It's called the morning surge. In the approximately 90 minutes after waking, from the moment you open your eyes to about an hour and a half later, blood pressure rises sharply in most people. This is biologically driven. As your body transitions from sleep, cortisol and adrenaline are released, heart rate increases, and the sympathetic nervous system activates. In young, healthy adults with flexible arteries, this surge is modest and well tolerated. In older adults with arterial stiffness, this surge can be dramatic. 20 points above nighttime baseline, 30, sometimes 40. Research published in the journal Circulation established that the hours between roughly 6 a.m. and noon account for a disproportionately large share of strokes and heart attacks in older adults, and that the morning blood pressure surge is a primary driver of this pattern. A major prospective study following nearly 520 elderly patients with hypertension found that those with a high morning surge had a stroke risk nearly 3 times higher than those with blunted surge. Even after accounting for their 24-hour average blood pressure, the average wasn't the issue. The morning spike was. What does this mean practically? If you take your blood pressure once a day, and you take it at 3 in the afternoon, you're measuring your most benign window. You may be completely missing the window during which your body is under its greatest cardiovascular stress. Your morning reading. Take it within 30 minutes of waking, before coffee, before any medication, before physical activity, is your most clinically important reading, and most people never take it. I had a patient I'll call Gerald, 71 years old, a retired school principal. His afternoon readings were consistently around 132/78, perfectly acceptable. He felt well. His physician was satisfied. On a hunch, I asked him to take readings for 2 full weeks at 3 specific times, within 20 minutes of waking, at noon, and at bedtime. His morning readings averaged 158 systolic. The same man who looked well-controlled in the afternoon was running dangerously high during the first 2 hours of every single day, right through his morning walk, right through his first cup of coffee. We adjusted the timing of one of his existing medications to better cover that morning window. His morning readings dropped to 134. His afternoon readings were unchanged. If we had never measured the morning, we would never have found the problem. Measure your blood pressure in the morning. Do it before you do anything else. It is one of the most important habits you can develop. Everything I've told you so far assumes one thing, that your readings are actually accurate, and that is a much bigger problem than most people realize. I regularly see patients whose blood pressure readings are artificially inflated by 10, 20, even 30 or more points, not because of their actual blood pressure, but because of how the measurement was taken. There are 5 specific mistakes I see constantly. Mistake 1. not resting before you measure. Blood pressure rises immediately with physical activity, even walking across a room. The American Heart Association guidelines recommend a minimum of 5 full minutes of quiet, seated rest before any blood pressure reading. Not 2 minutes. Not, I just sat down. 5 full quiet minutes. This is not optional. It is the single most important step in accurate measurement. Mistake 2. Measuring over clothing or with your arm in the wrong position. The cuff must sit directly on bare skin, not over a sleeve, not over a thin shirt. And your arm must be supported at heart level, not hanging at your side, not resting in your lap below heart level. A lowered arm position alone can add 8 to 10 points due to the pressure created by blood pooling downward. Mistake 3. Using the wrong cuff size. A standard adult cuff placed on a larger arm will produce falsely elevated readings, sometimes significantly. This is extremely common and almost never checked. If you're unsure whether your cuff size is correct, ask your pharmacist to verify it. It matters far more than most people assume. Mistake 4. Full bladder, cross legs, or talking during the measurement. A full bladder raises systolic pressure by an average of 10 to 15 points. Cross legs add 5 to 8 more. And talking during the measurement, even responding casually to a nurse's question, adds another 10 or more. That a potential 25 to 30 additional false points from things you can entirely control. Mistake 5. Taking only one reading and trusting it. Blood pressure varies naturally from minute to minute. A single reading in isolation is nearly meaningless as a clinical data point. The correct approach is to take 2 readings, 1 minute apart, and use the average or the lower of the 2. Then track a pattern over time. At minimum, a full week of morning and evening readings. Here is a complete protocol I recommend to every patient over 60. 5 minutes of quiet, seated rest, feet flat on the floor, back supported, arm bare and at heart level. 2 readings 1 minute apart. Recorded twice daily, once within 30 minutes of waking, once in the evening. 7 consecutive days. Average all the readings. That average is your real blood pressure. That is what should guide treatment decision, not one reading taken in an exam room while you're anxious and your coat is still on. One of the most common questions I receive: when does a high reading stop being something to monitor and start being something that requires immediate action? Here's the framework. A high number without symptoms is a signal to respond methodically, not a panic. If you take a reading and the number looks alarming, sit down, rest quietly for 10 minutes, breathe slowly, and retake it. In the majority of cases, a reading that initially seemed alarming drops significantly after genuine rest. Stress, anxiety, caffeine, the act of worrying about your blood pressure, all of these can spike a reading by 20 to 30 points temporarily. A high number with specific symptoms is a completely different situation. If your systolic is above 180 or your diastolic is above 120, and you are experiencing any of the following, call emergency services immediately. Do not drive yourself. Do not wait to see if it passes. The symptoms that make a high reading an emergency: a sudden, severe headache unlike anything you have felt before, chest pain or pressure, sudden difficulty speaking or understanding what someone is saying to you, changes in your vision or partial vision loss, numbness or weakness on one side of your face, arm, or leg, sudden severe difficulty breathing. These symptoms alongside a very high reading may indicate hypertensive crisis, blood pressure actively damaging organs in real time, brain, heart, kidneys, eyes. In this situation, minutes matter. That said, many people experience readings in the 170s or even 180s with 0 symptoms, particularly in the context of acute stress, anxiety, or poor measurement technique. This does not require an emergency room visit. It requires rest, remeasurement, and a same-day or next morning call to your physician. Know the difference between a spike and a crisis. That distinction alone may keep you from years of unnecessary medication, or save your life on the day when fast action is what counts. Let me bring this together. You now know that too high is not a single threshold. It depends on which number, which pattern, which time of day, and which direction the numbers are moving. You know the age-specific targets. Below 130 systolic for adults 60 to 74, below 140 for adults 75 and older. And you know that diastolic below 60 is just as dangerous as diastolic above 90. You know how to calculate your pulse pressure in 5 seconds, and why a gap above 60 is a warning your doctor may never mention. You know about the morning surge, the most dangerous window of your day, and why your morning reading is the one that matters most. You know the 5 measurement mistakes that can silently add 30 false points to any reading. And you know the correct protocol. And you know the difference between a spike and a crisis. Your blood pressure reading is not a verdict. It is information. And now you know how to read it. I'm Dr. Franklin. If this gave you something real today, please subscribe. Someone you care about may need to see this. Take care of yourself. The people who love you are counting on you.